Bismillahirrahmanirrahim. Now we are going to start with the myocardial action potential. So it also occurs in the bundle of His and Purkinje fibers. So the action potential, although when this name springs up, the only thing that comes to mind is like suppose this is the heart, so there we have an SA node and there's an AB node in the right atrium. So the action potential seems to be originating from these points, but you must also know that there are other regions of the heart which are capable of producing the action potential. These include bundle of His and Purkinje fibers. So the normal myocardial action potential is it has four phases. Phase 0, 1 to 3, 1 to 3. It has five phases, phase 0 to 4, and it looks something like this. And you must remember that we are talking about normal myocardium right now. We are not talking about SA node or AV node because the action potential of those two nodal areas is quite different from these ones. So the myocardial fibers, the muscles of the heart, the action potential that is conducted by them, and the bundle of His and Purkinje fibers which is present in the interventricular septum and the basically the nerve bundle which is present in the heart. So they have the action potential which looks something like this. So firstly we have phase 0, rapid upstroke and depolarization, voltage gated sodium channel open. So in this graph, as you can see that this part, this is phase 0, like this upstroke phase 0, that is mediated by the sodium influx. When we'll talk about the SA node and AV node, we'll see that there is calcium influx which is mediating that. So in myocardium, the phase 0 is mediated by the voltage gated sodium entry inside the cells. Then we have phase 1. So the phase 1 is initial repolarization. Voltage gated potassium channels begins to open. So in phase 1, this is phase 1 when the slight depolarization occur. It is because of potassium channels that start to open and potassium starts moving out, but this is counterbalanced by the calcium entry which happens in the plateau phase of the phase 2. In this phase, the calcium is entering the cell and potassium is leaving the cells, so the action potential kind of plateaus. There is a slight increase and then decrease, so we may say that there's a flat area in the action potential that is mediated by these two ions, and this is called as the phase 2. They're saying that the plateau, calcium influx of the voltage gated calcium channels and potassium efflux. Calcium influx triggers the calcium release from sarcoplasmic reticulum and myocyte contraction, decrease with the calcium channel blockers and increase with potassium channel antagonists. The phase 2, if we are giving calcium channel blockers to someone, the phase 2 will decrease, and if we are giving potassium channel antagonists, even then it will increase. Then it will increase. Then phase 3, that is rapid repolarization. Now the calcium channels are shut and the dominant effect is mediated by the potassium channels over here. This is the rapid repolarization phase in which the potassium efflux is the main contributor to the action potential. And here you can see that this is rapid repolarization, massive potassium efflux due to opening of the voltage gated potassium channels and closure of voltage gated calcium channels. Execution of potassium infusion, increase potassium in the extracellular fluid, no potassium efflux, and there will be no repolarization that can lead to arrest. So this is a terrible thing to happen, that sometimes you may have seen in movies or something that people just inject somebody with potassium. So the problem is that if there is too much potassium in the extracellular environment, like suppose there is too much potassium already accumulating in the extracellular environment, this potassium will not be able to move out. The concentration gradient will not allow this potassium to move out, and there will be no repolarization. So the cells will be arrested in a continuous depolarized state, and that will be called as a cardiac arrest. So that is why it is a very lethal thing. Then phase 4, resting potential. Now this phase 4, this particular phase between, it is basically the phase between two consecutive action potential, that is called the phase 4, and the heart is in the resting state in this time. High potassium permeability through the potassium channels, constant outward leak of potassium. Sodium and calcium channels are closed. The Uworld point is that the resting potential of cardiac in millisecond phase 4 is minus 90, not minus 70. Why? Why the resting potential is lower than the other cells to reduce the risk of arrhythmias, as larger stimulus is needed to excite the cells. Now, the cells will be excited only when they actually need to be excited. If it is like the threshold is lower, so there may be some unnecessary impulse that may be originating from some ectopic focus, and that can elicit a contraction. To avoid that, the threshold potential or the phase 4 potential is lower than the other tissues of the body. Instead of minus 70, it is minus 90. In contrast to skeletal muscle, the cardiac action potential has a plateau, which is due to calcium influx and potassium efflux. Cardiac muscle contraction requires calcium influx from the extracellular fluid to induce calcium release from the sarcoplasmic reticulum. Calcium induced calcium release. It is very important that the calcium that is entering the cells in this part is helping the release of calcium from the sarcoplasmic reticulum. Then cardiac myocytes are electrically coupled to each other by gap junctions. Got it. So this is cardiac muscle contraction, and the cardiac muscle contraction, it starts from here. That is beta 1 receptors, which are linked GS proteins, increase the cyclic AMP, increase calcium, and increase contractility. So GS will stimulate the adenylate cyclase to convert the ATP into cyclic AMP. This cyclic AMP will stimulate the protein kinase A to phosphorylate the calcium channels and thus activating them and allowing the calcium to influx into the cells. This calcium will stimulate the sarcoplasmic reticulum to release calcium ions into the cytoplasm, and they will mediate contraction. The Uworld point is about verapamil is a calcium channel blocker but does not affect the skeletal muscles. Why? The skeletal muscles does not respond to extracellular calcium and do not require extracellular calcium influx for excitation contraction coupling, and calcium comes from sarcoplasmic reticulum, not from the outside. In the cardiac muscles, the release of calcium from the sarcoplasmic reticulum requires extracellular calcium to come inside first. But in the case of skeletal muscles, the calcium is already stored inside the sarcoplasmic reticulum and no influx of calcium is required, and that is why the action potential of skeletal muscle looks something like this and this. So there is no plateau phase, there is no entry of calcium into those cells. So that is why the verapamil, the calcium channel blocker, will not affect the skeletal muscle contractility. Cardiac and smooth muscles depend on the extracellular calcium entering by the voltage-gated L-type calcium channels for excitation contraction coupling. So effect of verapamil on cardiac muscle, calcium induced release. Okay. So in the normal state, L-type calcium channels, they enter the cell, they stimulate the ryanodine 2 receptors, and thus the calcium will release from the sarcoplasmic reticulum into the cytoplasm. If the verapamil is blocking them, the calcium will not enter, and the calcium pockets of these ryanodine receptors will be empty, and thus the calcium will not enter the cytoplasm. Then we have pacemaker action potential. The pacemaker action potential is different from the myocyte action potential. This is the myocyte action potential, and this one is the pacemaker action potential. It looks different, and it is mediated by different ions. As you can see, the phase 0 in the myocyte action potential is mediated by sodium, while the phase 0 in the pacemaker action potential is mediated by calcium. So that is a different thing. Now here you can see that the pacemaker action potential occur in SA node and AV node. The key differences from the ventricular action potential include phase 0, upstroke, opening of the voltage-gated calcium channels. Fast voltage-gated sodium channels are permanently inactivated because of the less negative resting potential of these cells. They are permanently inactivated because of the less negative resting potential of these cells. Okay, results in a slow conduction velocity that is used by the AV node. Okay, so just give me a second. So this results in a slow conduction velocity that is used by the AV node to prolong the transmission from the atria to the ventricles. Phase 1 and 2 are absent. They are not present in the action potential. As you can see, there are only 3 phases: phase 0, 3 and 4. So these are 3 phases, 1 and 2, which was initial repolarization and the plateau phase. They are not present in the pacemaker cells. Phase 3 is repolarization, inactivation of the calcium channels and increased activation of the potassium channels, and there will be increased potassium efflux. Phase 4 is slow spontaneous diastolic depolarization, and that occurs due to closure of repolarizing potassium channels, slow influx of sodium through the funny channels, and opening of the T-type calcium channel. As you can see that this phase 4 in this situation in the skeletal, in the myocytes, it is a flat line, while in this case it is up slanting slope, and this is mediated by the funny sodium channels which open to allow the sodium currents to flow inside, and also by the closure of repolarizing potassium channels. Now the potassium is not leaving the cells and sodium is entering the cell along with the calcium, so that is what is happening right now. Then we have IF channels, which are the funny sodium channels. So they're responsible for slow mixed sodium potassium inward current, different from I and A in phase 0 of ventricular action potential. Like these cells are different from the sodium channels which allow the sodium in the phase 0 myocyte action potential, and these channels, IF channels, are inhibited by the ivabradine, account for automaticity of the SA node and AV node. The slope of phase 4 in the SA node determines the heart rate. Okay, so this slope will determine the heart rate. Got it? If it is more, more, what do we call that? If the slope is high, or if it is more vertical, if it is a vertical slope, so the heart rate will be high, like it will look something like this. And if the slope decreases, like if it lies down, like if it becomes like this, so the heart rate will be slow, like not straight line, but I hope I'm conveying the point that if the slope decreases, the heart rate decreases. If the slope increases, the heart rate will increase. Moving forward, this is cardiac pacemaker action potential. Here you can see that the sodium funny current and the calcium T-type channels are entering the cells, while the potassium is not leaving the cells, and that is giving this upslanting phase 4. Then this phase 0 upstroke is given by the calcium L-type calcium channels. Now these calcium channels are different from these ones which are T-type, and then the repolarization phase is mediated by the potassium influx. Got it. So here you can see the phase 4, phase 0, and phase 3. Then threshold potential, the amount of depolarization required to initiate the action potential, increased by class 1 antiarrhythmics, sodium channel blockers, and class 4 calcium channel blockers. Okay. Role of verapamil in the pacemaker action potential slows the diastolic depolarization by decreasing the calcium influx during the phase 0 and the later part of the phase 4, and they decrease the rate of SA node firing and slows the AV nodal conduction. Like if we are giving calcium channel blockers, so they will slow the calcium influx over here and also over here, so heart rate will be decreased. Yeah, so SA nodal firing will be decreased, and the calcium AV nodal conduction will be decreased. So all of as a whole, basically the heart rate will decrease. Yeah. The role of adenosine and acetylcholine in the action potential pacemaker cells affect phase 0 of the action potential, reducing the rate of spontaneous depolarization in the cardiac pacemaker cells. Inhibits the L-type calcium channel, further prolonging the depolarization time. These actions result in a transient slowing of the sinus rate and an increase in the AV nodal conduction delay. Adenosine is useful in termination of paroxysmal supraventricular tachycardia. Myocytes activates the potassium channels and increase the potassium conductance. Membrane potential remain negative for a longer period. Acetylcholine behaves similarly by increasing the outward potassium conductance while decreasing the inward calcium and sodium currents during the phase 4. So these are the membrane potential, as you can see, that like if we give what have we given, acetylcholine or what, and what was that, like what activates the potassium channels? These are not myocytes, this was some drug. By increasing the outward potassium conductance while decreasing the calcium and sodium current during the phase. So I think it is like we have administered acetylcholine over here, and that has slowed the conduction. Then comes the norepinephrine and sympathetic system on the pacemaker action potential. Open L-type calcium channel and sodium channel in phase 4 decrease time taken to reach the threshold, and there will be increased automaticity. Ivabradine, it is a drug that I was talking about previously, that blocks the IF channels. So drug that decreases the heart rate without affecting the contractility. As it acts on the phase 4 of the SA node, unlike other drug decreasing the heart rate, ivabradine selectively inhibits the funny sodium channels, prolonging the slow depolarization phase 4 and slowing the sinoatrial nodal firing rate. It has a negative chronotropic effect with no effect on the cardiac contractility, inotropy, and or relaxation, that is lucitropy. Used in chronic heart failure and decreased ejection fraction and persistent symptoms despite appropriate treatment. Decreased risk of hospitalization due to heart failure. Ivabradine mechanism of action is that it inhibits the funny sodium channels, and this is how it is going to work. Ivabradine reduces the slow diastolic depolarization phase. The inotropic agent means they will increase the contractility by increasing the inward calcium currents. The chronotropic agent increase the heart rate by increasing the inward sodium current and increasing the SA nodal firing. And dromotropic effect, they will increase the conduction velocity through the AV node and by increased inward calcium current. Pacemakers are SA node, other pacemakers. So SA node is dominant pacemaker of the heart. Location is at the junction of right atrium and the superior vena cava. So that is that the location is important, that it is located, like suppose this is the right atrium over here. So, and this is the superior vena cava entry into the right atrium. So it is located at the junction of right atrium and superior vena cava, somewhat over here, right? And the heart rate is 60 to 100. It is not difficult to remember because the normal heart rate is mediated by the SA node, and that is 60 to 100 beats per minute. Other pacemaker exist but are slower. If SA node fails, others will take over. Now, suppose this is again the heart, this is SA node, but the other ones which can play the part of pacemaker is AV node. Then we have bundle of His, then bundle branches. Like there are two bundle branches. They can play the role, and Purkinje fibers. Yeah, the Purkinje fibers are like, I guess, the sub branches of them. So these are the pacemakers. Now in normal situation, the intrinsic pacemaker activity of AV node, bundle of His, and these bundle branches and Purkinje fiber cells is lower in comparison to the SA node. As you can see, it is 60 to 100 beats per minute. It is maximum. Others are like 40, 25 or 25ish. So maximum rhythmicity or maximum pacemaker activity supplied by the SA node. This pacemaker activity suppresses these ones, and when they are under suppression, like these things, so due to this, when these are suppressed, so they cannot contract. But suppose due to some problem, either there is defect in the SA node, or maybe there is some atrial fibrillation, or some problem is going on. So in these situations, either the immediate next available pacemaker will take the role. If it is like, if AV node is intact, AV node becomes the pacemaker. If it is also gone, then comes a bundle of pace or something on those lines, and the heart keeps on beating. So AV node located in the posterior inferior part of the interatrial septum. Blood supply usually from the right coronary artery for the AV node, like, because of, we have talked about that a lot, that suppose this is the posterior side of heart and it is the right coronary artery which is moving backward and giving the posterior descending artery, and this will give an order branch to the AV node. 100 millisecond delay allows time for ventricular filling. It is important that initially the atria contract, and from between the contraction of atria and ventricles there is a delay of 100 milliseconds. Now it is when the SA node is the pacemaker. So we are just talking about the normal functionality. While SA node is the pacemaker, it causes the atria to contract, and then for the impulses to be conducted from the atria to the ventricles via AV node, there is a delay, and that delay allows the ventricles to fill completely. Then the bundle of His has an intrinsic heart rate, beating rate, or the heart rate of 25 to 40 beats per minute. Same is true for bundle branches and Purkinje fibers. Then comes the conduction velocity. This is a very important or beautiful graph. So you can see that the cardiac conduction velocity, the fastest is for the Purkinje system, then atrial muscle, then ventricular muscle, and the slowest is the AV node. So Park at the Venture Avenue, it's a mnemonic. So Park is the Purkinje system, is the fastest conduction system. A is for the atrial fibers, then comes the ventricular muscle, because there's no because, but I think that the ventricular body is so thick that the impulses, it is difficult for the impulses to pass on slowly, or I think something on those lines. And then avenue is the AV node, which is the slowest conductor. So slowest conduction is through the AV node, very important. So ventricle has time to fill. Purkinje fibers is the fastest conduction, so it is Purkinje, atria, ventricle, and AV node. Conduction pathway: SA node goes to atria, then AV node, bundle of His, right and left bundle branches, Purkinje fibers, then the ventricles. This is the normal pathway. Left bundle branch divides into left anterior and posterior fascicles. Determining the heart rate. So there must be 3 to 5 boxes between the Q or S complex. Normally there are 3 boxes, right? So like it is one QRS complex, it is the next. So there are like 1, 2, 3 and 3.5. So if there are 3 boxes, so the heart rate is 100, and if it is 3.5, so I guess it is 75 beats per minute. Like, it is when it is 3 boxes it is 100, when it is 5 boxes it is 60. So the heart rate must be between 60 to 100. Anything less than 60 is bradycardia, anything more than 100 is tachycardia. It was a crude definition, but maybe there is some defined definition later on. So here you can see the conduction pathway. This is the SA node, then comes the which supplies the atria, and then the impulses are transferred through the AV node to the bundle of His, which take them to the bundle branches, left bundle branch and right bundle branch, and then comes the Purkinje fibers. This is ECG. So in the ECG tracing, there are some things that you must know right now, and then we'll discuss them in detail when we do the step 2 sessions, inshallah. So the very first thing is that it has four important 1 2 3 4 5 6, yeah, five important components, and this is an additional one. So P, Q, R, S, and then T. These are very important. Now, the segment is a region which does not include a wave. It is the part between the waves. And if it also includes the wave, then it becomes interval. As you can see, the PR segment is between the P wave and the QRS complex. ST segment is between the QRS complex, or you may say the S wave and the T wave, right? These are segments. The point intervals like PR interval is between the P wave and the QRS complex. It does not include the QRS, but it is like between, it includes the P waves. QRS interval includes three waves, Q, R, and S. And QT interval, which is very important when we talk about torset to point this and something. So it includes the QRS complex and the T wave. Now this U wave is important when we are talking about potassium levels in the body. Hyperkalemia leads to peaked T waves. Hypokalemia leads to U wave formation. So U wave is for the hypokalemia, and peak, I'm sorry, there was T waves. I'm really sorry. It was not U waves. U waves are present in the hypokalemia, and peaking of T wave is seen in the hyperkalemia. So then we have P wave. The P wave is atrial depolarization, and it comes before the atrial depolarization. We have seen that in the previous videos. So atrial repolarization is masked by the QRS complex. That is why it is not evident, or it is not seen on the ECG. What happens if we say that there are no P waves? So in those situations, they will, if there are no P waves and the rhythm is irregular, then it is atrial fibrillation, and the rhythm will be irregularly irregular. If it is a regular rhythm with no P waves, then these can be hidden P waves or retrograde. Retrograde P waves, supraventricular tachycardia, or ventricular tachycardia. Like even in the simple ventricular tachycardia, the P waves can be hidden in the continuous or in the very tachycardic ventricular rhythm. So you must, if there are not P waves, then you are supposed to look for the rhythm. P waves present, and then there are irregular rhythms. Then the differentials include sinus rhythm with the premature atrial contractions, multifocal atrial tachycardia, or sinus tachycardia, or sinus with the AV block. PR interval, time from start of atrial depolarization to start of ventricular depolarization. It reflects conduction through the AV node. Normally, it is less than 200 milliseconds. If it is more than 200 milliseconds, first degree heart block is said to be present. QRS complex, ventricular depolarization phase 0 in the ventricular contraction in myocardial action potential curve. Normally less than 120 milliseconds. Wide QRS more than 120 milliseconds. The bundle branch block or ventricular tachycardia. QT interval, it represents the time taken from the ventricular depolarization and repolarization. Effectively, the period of ventricular systole from the ventricular isovolumetric contraction to the isovolumetric relaxation, mechanical contraction of the ventricles. The QT interval is shortened in hypercalcemia, and it is prolonged in hypocalcemia, drugs, and long QT syndrome. We'll talk about them later on. So the QT interval is shortened in the hypercalcemia, and it is prolonged in the hypocalcemia, drugs, and long QT syndrome. The T waves, ventricular depolarization, T wave inversion may indicate ischemia or recent myocardial infarction. Peaked T waves are seen in early ischemia, hyperacute, and also in the hyperkalemia. The J point, this is the J point. This one, it is the junction of the S wave with the isoelectric line at the ST segment. So the J point is junction between the QRS complex and the start of ST segment. ST segment is isoelectric, like ventricles depolarize. Isoelectric means that these are fluctuations due to the movement of current. There is no net movement of current towards or away from the leads which we have applied on the chest, so that is why it is an isoelectric line. Then we have the next point, that is U wave, so prominent in hypokalemia. Think hypokalemia and bradycardia. And also the peaking of T wave is seen in early ischemia, and hyperacute T waves are present and increased potassium levels, which means hyperkalemia. Okay, so then we have QRS axis. So the QRS axis is, normal QRS axis is minus 30 and plus 90 degree. Like this is plus 90 degree and minus 30 degrees. that is 0 and minus 90. So how is it minus 30 degree? But okay, it is the normal QRS axis. The axis of heart tends to move towards the hypertrophied tissue. Wherever there is hypertrophy, the axis will move toward that and away from the infarcted tissue. You must remember these 2 points, that the axis of heart moves towards the hypertrophied tissue and away from the infarcted tissue. In right axis deviation is seen in the right ventricular hypertrophy, because you know that axis deviates toward the hypertrophied tissue. So right ventricular hypertrophy, MI, on the left, like if it is left-sided MI, the axis will move towards right, and conduction deficit on the right will also cause the right axis deviation. And same is true, the reverse is true for the left axis deviation, like in the left ventricular hypertrophy, MI on the right side and conduction deficit on the left side. Now this is a diagrammatic representation. This is normal QRS axis, minus 30 and plus 90 degrees. Okay, between minus 30 and plus 90 degrees. Left axis deviation is seen in the ventricular rhythm and left bundle branch block. Right axis deviation is seen in the right bundle branch block and right ventricular hypertrophy. Okay, then we have access quick method. First glance at the AVR, it should be negative. Okay, so the AVR lead must be negative. Then if upright, suspect limb lead reversal. So firstly look for the AVR. If it is negative, so it's okay. Like if it is not negative, or if it is upright, we are talking about the QRS complex of the AVR. If it is above the line, so it means that you have not placed the leads in the correct fashion. Do that first. So this is lead 1. This is normal, and this is physiological left. I don't know what does that mean. This is left and right. Left axis deviation, right axis deviation, and lead 2. Okay. Okay, if the QRS complex in the lead 1 is pointing downwards, it is right axis deviation. If it is pointing upwards, it is either normal or left axis deviation. In the lead 2, if the QRS complex is pointing downwards, it is left axis deviation. If it is pointing upward, it is right axis deviation. Torsion the pointus, it is twisting of the points. Polymorphic ventricular tachycardia, characterized by shifting sinusoidal waveform on the ECG, it can progress to ventricular fibrillation. Long QT interval predisposes to torsade the points caused by the drugs, decreased potassium, decreased magnesium, decreased calcium, and congenital abnormalities. Treatment include magnesium sulfate. So to treat the torsade points, we can give magnesium sulfate. Okay, then we have congenital long QT syndrome. Inherited disorder of myocardial repolarization, typically due to ion channel defects, increased risk of certain cardiac deaths due to the torsade de pointes. It includes Romanov-Ward syndrome and Jervell and Lange-Nielsen syndrome. The Romanov-Ward syndrome, it is autosomal dominant, pure cardiac phenotype, and there is no deafness in the Romanov-Ward syndrome. And Jervell-Lange-Nielsen syndrome, autosomal recessive and sensory neural deafness. So when you listen a name this long, you become deaf, right? You become functionally deaf when you listen a name like Jervell Lange Nielsen. You actually have not listened anything. You don't remember anything after listening to that, so you're like kind of deaf to that. So that is how I remember this. That like it is the Jervell Lange Nielsen. The longer name is associated with a sensory neural deafness and also autosomal recessive. While the Romanov-Ward syndrome, it is pure cardiac phenotype and there is no deafness associated with that. Along with that, it is dominant. So Romanov-Ward, like there is Romano, so there is no deafness. No is for no deafness. Drug-induced long QT ABCDE, antiarrhythmics class 1A and 3, antibiotics like macrolides, antipsychotics like haloperidol, antidepressants, for example, tricyclic antidepressants, and antiemetics like ondansetron. Then we have Brugada syndrome. It is autosomal dominant disorder, most common in the Asian males. Mutation in the cardiac sodium channels, ECG pattern of pseudo-right bundle branch block, and ST elevation in V1 to V3 will be seen. So the ECG pattern is important. That ECG pattern of pseudo-right bundle branch block and ST elevation from V1 to V3 will be seen. Increased risk of ventricular tachyarrhythmias and sudden cardiac death is associated with the Brugada syndrome, and that is a mutation in sodium cardiac channels. Prevent sudden cardiac death with implantable cardioverter defibrillator (ICD). Patients with schizophrenia appear specifically more likely to have Brugada syndrome for some reason, but the people who have schizophrenia, they're also more likely to develop Brugada syndrome. Now, these are the patients with Brugada have a pseudo right bundle branch block and persistent ST elevation in V1 and V2. So in type 1, ST elevation is like this is ST elevation. here you can see that it was supposed to go like this, but it is moving upwards. So is this ST segment elevation, if it is more than equal to 2 millimeters, a downsloping ST segment and inverted T waves, it is downsloping and it has an inverted T wave. So it is type 1. In type 2, ST elevation, although it is more than 2 millimeters, but there is a saddle back. Like if you have seen a horse, it has a saddle on its back and it is a U-shaped area. So here you can see a saddle back, ST wave configuration and upright or biphasic T waves. The next syndrome is Wolff-Parkinson-White syndrome. The most common type of ventricular pre-excitation syndrome, abnormal heart rhythm in which the ventricles of the heart become depolarized too early, which leads to their partial premature contraction. Abnormal fast SST conduction pathway from the atria to the ventricle, which is called as a bundle of Kent, is present. It bypasses the rate slowing AV node. Ventricles begin to partially depolarize earlier. The characteristic delta wave. This is a very important, diagnostic marker, that if the delta wave is present with a widened QRS complex and short PR interval on the ECG, this is Wolff-Parkinson-White syndrome. What is it? Delta waves with widened QRS complex and shortened PR interval on the ECG. It may result in the re-entry circuit like supraventricular tachycardia, recurrent temporary arrhythmia in otherwise normal person. It is Wolff-Parkinson-White syndrome. Don't slow AV node with, like in the if the person is having Wolff-Parkinson-White syndrome, he will definitely be having some sort of tachycardia or something. Don't slow the heart with digoxin, calcium channel blockers, beta blockers, or adenosine, but block the accessory pathway with antiarrhythmics like 1A and 3. So the Wolff-Parkinson-White ventricular pre-excitation, this is SA node, AV node. This is the accessory pathway. Normally the impulses start in the SA node and then they move to the atria first and then come to the AV node, and there is a delay of 100 milliseconds, and then it comes to the bundle of his and then come to the ventricles, right? But in Wolff-Parkinson-White syndrome, while the impulses are present in the atria, they are conducted downwards through the bundle of Kent. It is a connective tissue, or you may say fibrous tissue, which can conduct the impulses downwards. So this causes the fast depolarization and then repolarization of the ventricles. Now, normally these people are asymptomatic, but if due to some reason, because when the impulses come down, these impulses are moving in that direction, and this myocardial tissue is not yet repolarized, and these impulses kind of cancel each other's effect, and this does not re-enter the atria. The problem arises when we have a re-entry circuit. If due to some reason, when this impulse reached this point, this area became already repolarized, so this impulse can be transferred all the way in the retrograde fashion to the atria, and then a conduction pathway will start like this. This will be a re-entrant loop, and this re-entrant loop will cause the patient to become symptomatic, and there will be all kind of nasty complications associated with that. So this is Wolff-Parkinson re-entrant tachycardia, which may look something like this. Okay, then we have this is the delta wave. Like suppose normally it must go like this, but there is an upslanting PR interval. Yeah, it's not upslanting PR interval. PR interval has been shortened. Like this is the PR interval, which was supposed to go all the way till there, and then we have an upslanting delta wave preceding the QRS complex. So you can also find them here, and this is a very good picture of delta wave. And here it is a very classical picture, this one. So these are like showing delta waves, and there is QRS widening as well. The QRS complex is also wider than normal, and then we have shortened PR interval with the delta waves. Wolff-Parkinson-White syndrome, W means W wave. W is delta somehow. How do they call W delta? So W means just wave, not wave. Delta wave. W means that there will be an extra wave, that is delta wave. P is for PR interval shortened, less than 1.2 second, less than 0.12 second, and then other W means wide QRS complex. So these are three features of Wolff-Parkinson-White syndrome, that is the good mnemonic. This one is delta wave and something. Then atrial fibrillation. So chaotic and erratic baseline with no discrete P waves. There is an in atrial fibrillation, the P waves will be gone, because when we call fibrillation, it means that the contraction is not there. There is some frenzy electrical movement going on, but that electrical mobility is not causing any contractile movement. That is not causing contraction to occur. So that is basically called as chaotic or erratic baseline with no discrete P waves. That is atrial fibrillation. In between irregular QRS complexes, there will be irregular heartbeat. Risk factors. Most common risk factors include hypertension and coronary artery disease. occasionally seen after binge drinking like holiday heart syndrome. Atrial fibrillation can occur after drinking a lot of alcohol, can lead to thromboembolic events, particularly stroke. Treatment includes anticoagulation, rate control, rhythm control, and cardioversion. Okay, we'll talk about that in detail later on. Okay, then we have irregular rhythm. These are fibrillatory waves, as you can see over here, and the distance between the QRS complex is variable. Like this is a shorter distance comparison to like the 1, 2, 3, 4, 3.5 boxes. In this we have like 1, 2, 3, 4, 4.5 boxes, then 1, 2, just 3 boxes. So this is the distance between the QRS complexes is variable. It is irregular rhythm, and there are no P waves, just a fibrillatory pattern between the two QRS complexes. Then atrial fibrillation with thrombus formation. As you can see, a thrombus is being formed here. This is the blood clot, left atrial appendage, and atrial fibrillation. The Uworld point is that in atrial fibrillation, which factor determines the ventricular rate? It is the AV nodal refractory period. Atrial fibrillation occurs, so like the problem is in the atria, the impulses which are conducted to the ventricles are coming through AV node. So it is the AV nodal refractory period which will determine the ventricular rate. Atrial fibrillation occurs due to irregular electrical activity in the atrium. While some of the atrial impulses are transmitted to the ventricles, most are not due to the AV nodal refractory period. Then atrial flutter. In atrial fibrillation, there are no P waves present. In atrial flutter, in contrast to that, it is a risk factor for the atrial fibrillation to develop. Like it is a predisposing factor, you may say that, but it is a preliminary condition. Atrial flutter can worsen to become atrial fibrillation. So they will be sawtooth pattern, as you can see here. So a rapid succession of identical back-to-back atrial depolarization waves. The identical appearance account for sawtooth appearance of the flutter waves. Treat like atrial fibrillation. Definitive treatment is catheter ablation. And you may also see in this pattern that every P wave is followed by QRS complex and then comes another P wave. Okay, right? I think so. The atrial rate is approximately 300 and regular rhythm consists PP interval. Okay, so there is equal P to P intervals, right? Right. I think that every P wave is followed by a QRS complex, but the P to P interval is same and the Q to Q interval is also same. Then ventricular fibrillation, a complete erratic rhythm with no identifiable waves. It is fatal arrhythmia without immediate CPR and defibrillation. If you did not do immediate CPR, it can prove fatal. Then we have the next thing, no discernible rhythm is present in this area. Then we have AV block. In first degree AV block, the PR interval is prolonged more than 200 milliseconds. Benign and asymptomatic and no treatment is required. So like the PR interval will be prolonged, right? It is longer than usual, but it is not prolonged progressively. There's no progressive prolongation. There's just a prolongation of the PR, and all the PR intervals are equal and similar to one another, right? In second degree AV block, it is subdivided into two types: Mobitz type 1, which is Wenckebach, and Mobitz type 2. In Mobitz type 2, there is progressive lengthening of the PR interval until a beat is dropped. Like PR interval is smaller than PR2. Okay, so yeah, so PR2 is larger than PR1 and PR3 is larger than PR2. So the PR interval keeps on prolonging until there's a dropped QRS complex, and then comes the next beat. So progressive lengthening of the PR interval until a beat is dropped, a P wave not followed by the QRS complex. The level of block is usually the AV node. It is usually asymptomatic, variable PR intervals, variable RR interval with a pattern like it is regularly irregular. Like, you know, the distance between these two will be less than these two, and this will be less than these two, but there is a pattern associated with that. Like after every 3 beats there is a dropped beat, and then comes next 3 beats, and then there will be a dropped beat. So there is a pattern associated with that. Then comes the Mobitz type 2. So dropped beats are not preceded by a change in length. So the dropped beats are not preceded by a change in length of the PR interval as in type 1 due to the defect in the His-Preckenji system. Okay, so the beats are also dropped in Mobitz type 2, but there is no prolongation of the PR interval. Like it does not require the PR interval to keep on prolonging progressively, and then a beat will be dropped. It just drops a beat out of nowhere. Due to the defect in the Hesper-Kanji system for this reason, the PR interval is constant and the AV node is normal. As the AV node is normal, it may progress to third degree block, often treated with a pacemaker. Got it. PR1 is equal to PR2 and P waves with absent QRS. There is no difference between the PR intervals, just a dropped beat. So if there is progressive prolongation, it is Mobitz type 1 Venki back. If there is no prolongation, then it is Mobitz type 2. Then we have this thing like the P waves are normal. QRS complexes are usually not always wide due to the concomitant bundle branch block. PR intervals are always at the same duration. There are dropped beats. We are talking about Mobitz type 2, and the AV block is always is below the AV node, generally in the Hesper-Kanji system. Okay. So the Mobitz type 2 is due to the defect in the Hesper-Kanji system, and Mobitz type 1 is due to defect in what? In maybe some AV node itself. Okay. So here you can see that this one is a non-conductive P wave and a dropped QRS complex is present. Then after 1 to 3 beats, all the PR intervals are same, like they're a fixed PR interval, and then we have a non-conductive P wave, and then comes a fixed PR interval. So basically there's dropping of the beats without prolongation of the PR segment. In Mobitz type 1 there was prolongation. Second degree AV block. In Mobitz type 1, the level of block is AV node. ECG findings are progressive prolonged PR interval leads to a non-conductive P wave, and there will be group beating. QRS complex will be narrow. Exercise or atropine improves type 1 AV block. Vagal maneuvers like carotid sinus massage worsens the type 1 AV block. And the risk of complete heart block is, there is a low risk of that. Then we have type 2. So the level of block is below the level of AV node, for example, the bundle of Hess. ECG finding will show PR interval will remain constant with intermittent non-conductive P waves. QRS complex can be narrow or wide. Exercise or atropine worsens the type 2 AV block. Vagal maneuver, carotid sinus massage, paradoxically improves the type 2 AV block. And higher risk indication for pacemaker. Higher risk indication for the pacemaker. Okay. Then we have third degree AV block. So I guess we had just completed this, right? Exercise will worsen the type 2 AV block. Then vagal maneuvers, paradoxically they improve the type 2 AV block, but they worsen the type 1 AV block. So just remember that exercise and atropine, they improve the type 1, and vagal maneuvers worsen the type 1, and the reverse is true for type 2. And there's a high risk of indication of pacemaker, a high risk of complete heart block. So this is an indication for the pacemakers as well. The third degree block or the AV block, the pathophysiology is that the conduction between the SA node and the AV node is impaired, and the AV nodal cells become pacemaker. Like suppose this is the heart, and here we have the SA node, and this is the AV node. So the conduction pathway between these two is not functioning, like the impulses which are originating in the SA node cannot reach the AV node. So the AV node comes out of suppression, and now it is the pacemaker itself. SA node implants impulses causes atrial contraction. So the SA nodal impulses will cause atrial contraction, while the impulses generated on the AV node cause a ventricular contraction. So there is an atrioventricular dissociation in the sense that the atria are contracting separately from the ventricles. The ventricles are separating are contracting at a different or at a slower rate in comparison to the atria, because the SA nodal intrinsic rhythm is faster in comparison to the AV nodal intrinsic rhythm. The ventricular pacing is coming from the AV node, which becomes the pacemaker for the ventricles. ECG, there will be AV dissociation. The atria and ventricular depolarize independent of each other. P waves and QRS complexes are not rhythmically associated. QRS complexes are narrow. Since the ventricular depolarization proceeds normally, the AV node produces a heart rate of 45 to 55 beats per minute, usually treated with a pacemaker, and it can be caused by the Lyme disease, a type 3 heart block, third degree heart block, in which the atria and ventricles are beating separately. That is happening in the Lyme disease. So let's revise the type of heart blocks we have just studied. In the first degree AV block, there is just PR prolongation. There is fixed PR, but a fixed prolonged PR. That's it, right? In the second degree heart block, in Mobitz type 1, there is progressive prolongation of PR interval until the beat is dropped. And then we have Mobitz type 2, in which there is fixed PR interval with a dropped beat. This one is more dangerous. Then the type 3 is when there is AV dissociation. Then we have type, so here you can see that the PP intervals are same. P wave on the QRS complex, and the RR interval is also same. The PP interval is similar and faster, and RR interval is slower and similar to each other. So the atria are beating separate from the ventricles because the atrial rhythm is mediated by the SA node, while the ventricular rhythm is mediated by the AV node. Yeah. So here you can see that uh, it is also that I think it is a P wave, then P wave, then we have QRS complex, then P wave, then another P wave, or is it okay? It's hard to decipher. Either it is a T wave or a P wave. I don't know. This one is difficult for me to understand. I think these are P waves, like these two P waves, and then one QRS complex, two P waves, one QRS complex, an erratic P wave and another P wave, then QRS complex. So I think this is like that. Bundle branch blocks. Both branches blocked results in AV block, form of His-Purkinje system disease. One bundle branch is blocked, it does not cause AV block. Normal PR interval and QRS will be prolonged. Symptoms, there will be no symptoms. Identify incidentally on the ECG. May progress to AV block, need for pacemaker. Okay. We are done with the AV nodal blocks. So then now we're talking about bundle branch blocks. So we may, for the bundle branch blocks, uh, if one is blocked, it does not cause AV block, normal PR interval and the QRS will be prolonged, and there will be no symptoms identified incidentally on the ECG. It may progress to AV block, and then it will need pacemaker. Interfere with the detection of ischemia. ST elevation, T wave inversion can be normal. Causes, if often it is caused by slowly progressive fibrosis and sclerosis, more common in older patients, can result from structural heart disease. Left bundle branch block, prior myocardial infarction and cardiomyopathy can be a risk factor. And for the right bundle branch block, right heart failure can be a cause, or it can lead to that. I think it can be caused by that. Now this one is a very detailed explanation of ECG. Now in the right bundle branch block, the findings look something like this. The characteristic changes are prolonged duration of the QRS complex, like it will be more than 0.12 seconds. Okay, so QRS duration is prolonged in right bundle branch block, like it is a prolonged QRS. Small r SR, what is that? Formation in the leads, V1 and V2, sometime V3, characteristic M shape. So there will be characteristic M shape in the V3. There's no M shape in V3, but in V1 and V2. So like there will be a characteristic M-shaped QRS pattern in the lead V1 and V2. Wide S wave in leads V5 and V6. The S wave is wider in V5 and V6. Okay. Final negative intrinsicoid deflection in V1, V2 more than 0.03 milliseconds, and T wave inversion V1, V2 and V3. So there is T wave inversion V1 and V3. The 2 points that I remembered is M wave, M shape pattern in V1 and V2, S wave, prolonged S wave, right, wide S wave in V5 and V6, and inverted T waves in V1, V2 and V3, and also QRS interval will be prolonged. So this is what we see in the right bundle branch block. Then we have left bundle branch block. So in the left bundle branch block, I have to zoom it in. So they are saying that in 12 lead ECG paper, sinus rhythm with a heart rate of approximately 70 per minute, left axis deviation R more than S in 1. What is lead 1? This is lead 1. R more than S. What did that even mean? QRS complex will be wide. Okay. Single ventricular premature beat. This is a premature ventricular beat. Notched or M-shaped R waves. These are M-shaped R waves, as you can see in V6. So M-shaped R waves in V6 are present, like M-shaped QRS complexes are present in V1 and V2 of the right bundle branch block, while M-shaped QRS complexes are present in the M-shaped R waves are present in the this one. Okay. So V6 and the premature complex in all the precordial leads. Diagnosis left bundle branch block with ventricular extrasystole. Okay. Then we have the next thing, that is right bundle branch block characteristics. So this is V1 and this one is V6. Got it? And this is like that. RSR and R. I don't know. So I think there's a better explanation of these ECG on BNB and also in the sketchy. So do listen to that. Atyl natriuretic peptide and brain natriuretic peptide. So they are released from the atyl myocytes in response to the blood volume and atyl pressure. It acts via cyclic GMP. Mechanism of action that on the kidneys dilate the afferent and constrict the efferent. On the kidneys, it acts by dilating the afferents and what dilate the afferent and constrict the efferent arteriole, decrease the sodium reabsorption, decrease the renin, and that ultimately results in diuresis, contributing to aldosterone escape mechanism. We'll talk about that in detail. But the problem is that in people who have hyperaldosteronism, aldosterone can lead to salt and water retention. That too much salt and water retention can lead to excessive blood pressure, excessive hypertension. To avoid that, when there is too much salt and water retention, the atrial muscles, when they are stretched, they release atrial natriuretic peptide and ANP and BNP. That ANP and BNP will increase the GFR, and that will start increasing the natriuresis. So although there is excessive aldosterone and there is salt and water retention, but that does not go frenzy, and that does not that is limited by the ANP and BNP. Then adrenal gland. ANP act on the adrenal gland to decrease the aldosterone level and acts on the blood vessel to cause vasodilation and increase the capillary permeability. BNP, it is released from the ventricular myocytes in response to increased tension. Similar physiologic action to the atyl natriuretic peptide with a longer half-life. BNP, blood test used for diagnosing the heart failure, very good negative predictive value. It is available in a recombinant form, that is necitide, for the treatment of heart failure. Uworld point is about the neprilysin. Neprilysin cleaves and inactivates the endogenous peptides, including the natriuretic peptide, for example, the BNP, glucagon, oxytocin, and bradykinin. Inhibition of neprilysin, for example, sacubitril, leads to increased level of endogenous natriuretic peptides, which promote the beneficial effects in the heart failure. Okay, so inhibition of neprilysin. Neprilysin is an enzyme. We inhibit that with sacubitril. So the drug is sacubitril that can inhibit the neprilysin, and when neprilysin will not be there to inhibit the BNP, so we can get beneficial effect in the people with the heart failure. Okay, so renal effects of natriuretic peptide. They decrease intracardiac filling pressures, release of atyl natriuretic ANP and BNP, ANP by the atria and BNP by the ventricles. They increase the GFR by constricting the efferent and dilating the afferent arterioles, decrease the proximal sodium reabsorption, and decrease the renin secretion by the juxtaglomerular cells. So ultimately they cause natriuresis and diuresis. Then we have normal cardiac pressures. I think we should do that in the next session. So until next time, Allah Hafiz, fi amanillah, and take care.